Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hands.org/dental-training. For future inquiries, contact Facilitator.
Thank you so much for the very kind introduction. I really appreciate it. And it's an honor to be able to share my experiences in research with the group. Today, I will be talking about biologic and prosthetic risk indicators for peri-implant disease. Specifically, I'll be sharing some of my work regarding the periodontal phenotype and implant tooth interproximal contact loss as risk indicators for peri-implantitis. We know that risk factors are factors that are associated experimentally with pathologic conditions like peri-implantitis, and risk indicators have been associated in terms of prevalence for disease. So there's a little bit of a distinction that I want to make before I move forward between risk indicators and a risk factor. Overall, we know that strong evidence exists to implicate biofilm in the induction of inflammatory responses in both the gingiva of natural teeth and peri-implant mucosa. Inflammation of the peri-implant soft tissue is known as peri-implant mucositis, and this inflammation can trigger a catabolic osteoimmune response, which results in progressive resorption of the marginal bone at the implant site and is then diagnosed as peri-implantitis. Historically, there have been numerous guidelines to diagnose peri-implantitis, but clear terms and diagnostic criteria were introduced in the 2017 World Workshop classification. This 2017 classification introduced 3 terms specifically. The inaugural terms that were introduced were peri-implant health, peri-implant mucositis, and peri-implantitis. And how we diagnose these different conditions involve clinical and radiographic examination. So for peri-implant health, we must observe an absence of clinical signs of inflammation, no bleeding on probing or suppuration, no increase in periodontal probing depths that are clinically significant besides normal intra-operator variation, and then bone loss beyond initial remodeling. There should be none, and the threshold is set at 2 millimeters. For peri-implant mucositis, we may see signs of clinical inflammation like erythema and swelling of the soft tissues, or bleeding on probing or suppuration, and likely increase in probing depths, but there is still no bone loss beyond the initial remodeling threshold. As for peri-implantitis, we see clinical signs of inflammation, but we also see bone loss around the implant radiographically and clinically. And so you can diagnose this in 2 ways. If you have a baseline exam, which means that you have a baseline radiograph at loading of the implant, and then also periodontal charting, you can compare it, and the threshold for bone loss is 2 millimeters. But if you don't have any baseline evidence, then the threshold is slightly higher at 3 millimeters. Probing depth should be at least 6 millimeters for this diagnosis. And this is the diagnostic criteria that I personally have used in my research to stay current and relevant to how clinicians will be practicing and what guidelines they should be referring to at this time. So a lot of you probably know that there are certain doctors that say implants are easy, you just need to sink a screw into bone. But if it's so easy, then why do we have such high reports for peri-implantitis prevalence in literature? Dirks and Tomasi estimated that peri-implant mucositis actually ranges from 19 to 65%, and peri-implantitis ranges from 1 to 47% in a review of the literature. And part of the reason for these high rates is that there have been many papers where different clinicians are using different diagnostic criteria for peri-implantitis, and with a lack of baseline evidence to objectively show a difference in probing depth and marginal bone loss. In some of the papers, for example, the peri-implantitis rate that was reported to be at 47% at the high end of this range, they used a threshold of 0.4 millimeters for bone loss, which is well within the standard for initial remodeling based on the implant placement and different factors related to the placement. So overall, there's some papers out there that report maybe not such an accurate incidence or prevalence of disease. But more recently, in a systematic review, Rakic reported a weighted mean prevalence of peri-implantitis to be 18.5% on the patient level and 12.8% on the implant level. Peri-implantitis in this paper was defined as direct evidence of at least 2 millimeters of radiographic bone loss and at least 5 millimeter probing depths. Overall, in this paper, there are more conservative prevalence rates, but this still means that approximately 1 in 5 patients will experience a pathologic bone loss around their implants. And that's still fairly high and very significant to the patients that are affected. There are many potential factors that can influence risk for peri-implant disease. You might have patient-related factors such as periodontal disease. If you have pre-existing inflammation and you place an implant under these conditions, that can encourage the resorptive process involved in peri-implantitis. Excuse me one second. And lack of maintenance of the patient. You could have poor plaque control, and biofilm-associated inflammation is a core etiology of peri-implant disease. Patient could be smoking, there could be systemic disease or genetic factors involved. You also have site-specific factors. So before you place an implant, you should evaluate the site itself. What is the periodontal phenotype? What is the keratinized mucosa width, gingival thickness, buccal bone thickness? We know from Monhay that there's a critical buccal bone thickness of 1.5 millimeters to be protective against development of peri-implantitis. You should consider pre-existing pathology. If there was a tooth that had a periapical cyst or some kind of over-infection before placing the implant, and also the quality of the bone. And this also relates back to the patient factors. Do they have osteoporosis or osteopenia, some kind of medication that affects bone remodeling? These can all influence the bone quality. And then there's also implant-related factors such as the implant design, the implant material. Maybe you have ultra hydrophilic surfaces such as the SLA active surface. And then, you can consider the material in terms of how you maintain the implant. And I'm going to come back to that in iatrogenic factors. And then also the implant prosthesis. You have to think about, is it cement or screw retained? We know that submucosal cement is a strong risk factor for peri-implantitis. And many times, if we see peri-implantitis with submucosal cement, we have a pretty good chance of treating it because it's actually, there's a direct, obvious etiology for the peri-implant inflammation. Abutment height may influence peri-implant health, as well as the superstructure design and then emergence angle. We know Catafucci et al. Showed that emergence angles over 30 degrees were not as cleansable and not conducive to peri-implant health, and were actually associated significantly with peri-implantitis. Finally, there's iatrogenic factors that can be involved, such as the surgeon's skill level. Titanium particles may play a role when you place the implant, when you clean the implant, when you do implantoplasty. These things can all generate metal particles that may induce inflammation, may affect the type of macrophages involved in the healing and inflammation resolution process around the implant. So surface damage can also encourage bacterial growth on the implant surface. And then when you place the implant, using correct surgical protocol to prevent overheating. And finally, planning as well. The position is crucial. The 3D position of the implant buccolingually, mesial distally to their tooth, root proximity or implant proximity. You must respect all of the known distances that are kind of the guideline for promoting a situation that will allow peri-implant health. And overall, this shows me that we have a significant role in creating an environment for the implant that supports peri-implant health, because if you really think about it, many of these factors are modifiable to some extent by the surgeon and clinician themselves. There are intrinsic factors, such as patient genetics, that maybe at this time we don't have the technology to modify in the clinic, but out in the research world, it's being developed. We know that we can perform epigenetic modifications, perhaps by modifying the implant surface and using some sorts of gene therapy or targeted gene coatings to be able to actually modify the transcription and expression of certain types of beneficial genes to promote healthy osseointegration and peri-implant health. And so maybe that's something we will see in the future once that's translated into the clinic. But at this time, I consider it an intrinsic factor. But we have so many modifiable factors related to the patient and the implant and our own skills and surgical protocol. So we have a huge responsibility, and we also have a role in the complications that lead to bone loss. So this means that we should execute proper treatment planning, patient education, and implant maintenance so that we can really prevent as much of the peri-implant biologic complications that so often occur. This also leads me to ask the question, what % of peri-implantitis truly is preventable? Maybe rather than an intrinsic disease process beyond our control, it really is something that involves, like I said, all of that planning and implant care and maintenance. So I want to talk about a few factors that are modifiable by ourselves, by the clinician. There are some factors modifiable by the patient, but the factors that we can control should be identified and addressed by us. And so as periodontists in my field, we are largely responsible for creating a healthy soft tissue environment around implants. Specifically, I have assessed some important soft tissue factors that have historically been considered a little controversial in regards to whether or not they really promote peri-implant health. And these are keratinized mucosa width and the gingival phenotype. And if you're interested in reading my paper about it, I have provided a link to the paper using this QR code. And I will also talk about a prosthetic factor, which is interproximal contact loss. And I have also included the QR code here for anyone who's interested in reading this paper that we published in Clinical Oral Implants Research. Both of the study designs for these two papers were similar. They were cross-sectional studies. The first one involved 193 implants in 63 patients, and this interproximal contact loss study was 61 patients with 142 implants. So overall, in both of these studies, the study protocol involved 3 phases. The first was a clinical evaluation performed by calibrated examiners that included the plaque index, gingival index, probing depths, bleeding on probing and separation, keratinized mucosa width, gingival phenotype, and interproximal contact status, depending on the paper. And in the radiographic analysis for both, we measured contact to crest distance, marginal bone loss, and we also documented whether or not the implants were platform switched. And then we also conducted a survey or a questionnaire to assess patient-reported outcomes, and these include awareness of the open contact, food impaction experience by the patient, their oral hygiene behavior, and whether or not they had pain associated with the implant while brushing. So now I just want to define some of the terms I'll be using, and I want to reference a really great paper by Dr. Avila Ortiz et al. And this paper was a consensus statement to describe specific anatomic components of the peri-implant tissues and the dimensions of these components that may contribute to peri-implant health. And 2 components I'll be focusing on specifically are the keratinized mucosa width, which is the distance from the free gingival margin of the implant to the mucogingival junction, and then also the mucosal thickness, which is the horizontal dimension of the peri-implant soft tissue from the implant out to the surface of the gingiva or mucosa. And these are two components that have historically been associated with peri-implant health or disease, but again, have been controversial. There are many systematic reviews that assess these components that say that inadequate dimensions of these two factors may result in things such as mucosal recession, peri-implant bone loss, peri-implantitis. But then there are some papers that also have said that in the presence of good oral hygiene, that these things don't matter. And so why I did the study was to really assess what is the prevalence of peri-implant disease in terms of peri-implant mucositis and peri-implantitis separately and also combined in relation to these factors. So here you can see the gingival phenotype, which is essentially the keratinized mucosa width, but more in a clinical view. I used a clinical test so that clinicians could read my paper and see, this is a reproducible test that I can do myself that was developed and published by Dr. Joseph Kahn in 2010 using the probe transparency technique. And basically, you can use this very simple, non-invasive method to assess the implant clinically and then relate it back to the findings of my paper. And that's why I use this somewhat simple but straightforward method to categorize the implants. And overall, we found, there's thick and thin phenotypes. In a thick phenotype, we see no show-through of the probe through the peri-implant mucosa, whereas a thin phenotype will show probe transparency. And Joseph Kahn showed basically that in a thick phenotype with no show through, that reliably the gingiva or peri-implant mucosa specifically is over 1 millimeter in thickness. And in a thin phenotype, it's likely to be less than 1 millimeter. And so we also looked at the keratinized mucosa width while we were evaluating the implants. And this is a critical criteria that we allocated implant groups to as well. And to assess the keratinized tissue width or keratinized mucosa width, we used 2 millimeters as the cutoff for adequate versus inadequate based on previous literature. And again, we measured from the free gingival margin to the mucogingival junction, as you can see here. So over here, we have what is considered adequate keratinized mucosa width of at least 2 millimeters. And here we have inadequate keratinized mucosa. And interestingly enough, this is the same patient. You can just see that they're just different teeth involved. And so, you can have a localized amount of inadequate or adequate keratinized tissue, and we want to see if that's significant for the implant. Overall, in the study, the clinical outcomes that we found were that there was more peri-implant health associated with at least 2 millimeters of keratinized mucosa width. Here you can see 49% of the implants versus 29% of the implants were healthy. And then also 56 versus 30% of the implants were healthy in thick phenotype or versus thin phenotype. We also see more disease in the inadequate keratinized mucosa width group and the thin phenotype. So you can see the green, yellow, and red kind of disperses this into health, mucositis, and peri-implantitis. And you can look at it as, these three categories. There's obviously more peri-implantitis in these two groups where we predicted we would have a higher prevalence rate. But also you can look at it in terms of just overall disease too. So if you look at the red and yellow bars combined, you can really see a difference. There's significantly more inflammation in sites that have under 2 millimeters of keratinized mucosa in a thin phenotype. In terms of the gingival phenotype, we found a thin gingival phenotype was significantly associated with peri-implantitis, and there was actually a 3-fold prevalence for peri-implantitis with thin phenotype. We also saw nearly a 2-fold prevalence for peri-implant mucositis and nearly 4 times prevalence for pain during brushing or flossing. So patients with a thin phenotype reported significantly that they actually have discomfort while performing oral hygiene, and this may be a significant factor related to the higher prevalence of peri-implant disease. And so Although it may not directly influence the peri-implant pathophysiological process that results in bone resorption, we can't know directly. There may be like a reduced barrier to bacterial infiltration and inflammation overall with a thin phenotype. We also know that there's a patient-related factor involved, which is the pain during oral hygiene. And so doing a phenotype modification may be beneficial to prevent this from occurring. We also saw that in an adequate keratinized mucosa width, there was nearly a twofold prevalence for peri-implantitis, 1.5 for peri-implant mucositis, and almost 2.5 prevalence for pain. So again, there was a little more discomfort associated with inadequate keratinized mucosa width in terms of oral hygiene for patients. And there was an increase in the prevalence for peri-implant disease, but not as marked as the thin gingival phenotype. And one of the reasons I believe it was less pronounced for this specific factor was that you can have, we measure the mucosa width from the gingival margin to the mucogingival junction, and you can have, say, like a 3 mm band, but if the probing depth is also 3 mm, that means that it's not attached. So I think in the future, studies should really consider that. And that's something that I would have improved from my study specifically. But you want to also consider what amount of that keratinized mucosa width is attached. And I actually think that may be more important. So how do we address this factor? I said that there are factors that are modifiable by us, and you might think, oh, well, the patient presents with this type of gingiva, that's what they have and that's what they get. But, that's not true, because we know we have surgical phenotype modification therapy to improve the soft tissue parameters around an implant. And so one of my faculty at the Harvard School of Dental Medicine, Dr. Lorenzo Tavelli, published with his group from Michigan a really important systematic review and network meta-analysis that shows that we can increase mucosal thickness using bilaminar techniques with soft tissue grafts. We can increase keratinized mucosa width using an apically positioned flap in combination with free gingival graft as the gold standard treatment. And that bilaminar techniques with CTG or CMs have beneficial effects on marginal bone stability overall. So we know that we can treat these defects with different types of collagen matrices or autogenous tissue and actually promote a better environment for peri-implant health. So now I'm going to talk about the next factor that I assessed, and this is interproximal contact loss at implant sites adjacent to natural teeth. And what you see here is actually contact loss between an implant restoration and an adjacent natural tooth, which is a highly prevalent prosthetic complication reported in the literature. In a prospective study by Xie et al., they actually found in 144 dental implants that nearly a quarter of them experienced interproximal contact loss, and this occurred as early as 3 months. And we also know that interproximal contact loss may occur at a rate between 18 to 66% in the maxilla and 37 to 54% in the mandible. There are a variety of proposed mechanisms for contact loss, but the most widely accepted theory is that the wear of interproximal tooth surfaces result in mesial drift of natural teeth to close the space, which in combination with the essential ankylosis of dental implants results in an open contact. Other commonly proposed explanations include continued craniofacial growth in adulthood and crown-related factors. So in my study that I used to that I assessed the interproximal contact loss, I used a clinical assessment for this one as well, something that anybody can do. And all I did was use fine unwaxed floss in a clinical test to assess if a contact between the implant site and the natural adjacent tooth allowed unrestricted passage of the floss. And if it did, it was deemed open. Then the open contacts were measured with a leaf gauge that's traditionally used in orthodontics for interproximal reduction. And each gauge of the leaf has different thicknesses. And so if it passed through without any resistance, because you can wedge them through, but you don't want to actually do that because you're actually moving the adjacent natural tooth a little bit with the physiologic mobility, or possibly pathologic if it has some disease process around it. But you want to allow unrestricted passage of the leaf gauge as well. And this allowed me to categorically, assess the implant to natural tooth contact distance. And then you can see here's an example of me measuring an open contact in a patient. And so overall, we found that there was a higher prevalence of open contacts in posterior implant sites. We also found quite a few open contacts in the maxilla, but it was pretty similar. There was no significant difference statistically between anterior, posterior, maxilla, and mandible in terms of the ratios. But we did find that there was a significant association of open contacts on the mesial contact of implant sites. We found that actually 68.5% of the open contacts involved the mesial surface of the implant, which aligns with the hypothesis that mesial drift of natural teeth results in an open contact. And you can see here some radiographs where you can actually see the open contacts. And this is not always the case, so I wouldn't rely on a radiographic evaluation, and that's why I did a clinical assessment. But we found that 54.2% of the implants had open contacts, and this is quite significant. In terms of contact distance, we found that their distance had no association with peri-implant disease, but overall there was most of the contacts were about 0.1 millimeters in width. And even though we didn't find an association with the width, we still found an association with the presence of the open contact itself. And so here you can see the clinical outcomes. Again, note that the peri-implant health prevalence is much higher in implants with closed contacts, whereas disease and more severe inflammation or gingival index score and higher plaque scores were associated with the open contact. So, we can infer from these findings that if you have an open contact, you may have more food impaction, more plaque accumulation, and thus with the biofilm related etiology, more inflammation around the implant in the soft tissue and eventually progressing to the bone. And so that's why we see more peri-implant mucositis and peri-implantitis in implants that have an open contact. And in terms of patient-reported outcomes, 1/3 of patients were aware of their open contacts, and over half noticed food impaction. And patients with open contacts, at a patient level, it was 75.4%. So 3 in 4 of 4 patients actually had open contacts based in our study. And then we also found that half of all implants had open contacts. And overall, we found that there was a 1.5 prevalence for peri-implantitis. So what this tells me is that patients notice when they have an open contact at an implant site. It affects the patient. It's quite common, and it may be related to a pathologic process of inflammation around the implant. And so not only is it bothersome to patients, but it can actually diminish their experience with the implants and possibly result in biologic complications. So overall, again, we saw that 1/3 of patients were aware of the open contacts and over half noticed the food impaction, and there was nearly a 3-fold prevalence for pain during oral hygiene, which is significant and something that could affect the treatment outcome for our patients. Overall, I would like to just state that, open contacts are extremely prevalent prosthetic complication in implant dentistry. I encourage you all to check your implants, check the crowns at maintenance visits and really assess if they're an open contact or not, and consider what you can do for this issue. It's disappointing, that we prepare the site surgically, ensure that the soft tissue and hard tissue parameters are ideal, plan cases digitally with extreme precision, use a very refined surgical protocol and loading protocol restoratively, and then possibly within 3 months, the patient can develop an open contact. This is a significant problem. And, in dentistry, if we have a class 2 filling with an open contact, we drill it out and redo it. If you get a crown for the lab and it has an open contact, you send the crown back. And so if we do all this planning and have open contacts at our implant sites, in which patients have invested heavily in terms of their finances and their time, then I think that this is a major problem. And so I just want to emphasize, I detected open contacts in over half of the implants in my study. They're most frequently observed in posterior sites, and the mesial surface is most commonly involved. So I really encourage everyone to check this. And in terms of prevention, there's no literature to show that there's actually any effective way to prevent it. There have been studies that used tighter contacts at loading to try to prevent it, but it wasn't really that successful to prevent the open contact. And the only solution or possible approach that I would consider at this time, based on what I've read and speaking to experts in the field, such as Dr. Dennis Tarnow and Stephen Chu, is that a retainer may be recommended to prevent interproximal contact loss. And oftentimes, anyways, implant patients, I like to prescribe them occlusal guards because I believe a lot of them have parafunctional habits anyway. And so I think that this could not only protect their teeth, but also potentially prevent the interproximal contact loss. And that should be an area of future research. Briefly, I would like to thank my study team back home at the University of Washington, where I conducted the clinical portions of the study. Drs. Amit Garpare, Justin Kong, my PI, Diane Dauber, and Dr. Faisal Al-Jofi, my other colleague. So I want to give them special thanks, and I appreciate all of their significant contributions to this research, and it was great working with them as a team. And then finally, if anybody would like to contact me, you can email me, find me on Facebook, and also find me on Instagram as the Perio Artist. I do educational drawings on Instagram about periodontal topics and peri-implant surgery, implant surgery, and some general dentistry topics as well. So I'm really pleased that I was able to present to all of you today and share my work. And at this time, I'd be happy to answer any questions.
All right. Do we have any? Thank you so much, Dr. Latimer, for that very, very detailed. Dr. Latimer is well, she's going to hear here today. She's an inspiration. Okay. When I see her drawings, I'm like, wow, I get to understand cells and very detailed, and it's inspired me to do further. I'm telling my mates here that I'm going to do some post-grad in perio when I leave here, just because of the interest. I'm just interested in implant surfaces. So do you have any, do you think implants, I was listening to a video recently, is the implant surface, does it have anything to do with peri-implantitis?
I think that, with use of modern surfaces, that we don't really have so much of an issue with peri-implant disease. I think that in the past, with like the coatings that would come off of the implant surface, that was associated with peri-implant inflammation. But one thing to also consider, like in terms of like micro-roughened surface or SLA active surface, like reductive processes to create the micro-rough surface versus like polished surfaces, where these surfaces are in relation to the bone, in relation to the tissue, how susceptible is it to bacterial infiltration, and also what happens when we attempt to clean these surfaces, how polishable are they if you're trying to do implantoplasty. I personally don't practice implantoplasty because if you modify the surface with like a Cavitron unit or drilling the surface off, then you're removing the like the compatibility of the surface with the biological tissues around it, because you're just grossly cutting it off at a macroscopic level. Yeah. And if you think about it at a microscopic level, you're actually removing all the elements that make it conducive to forming bone and allowing osteoblasts to adhere to the surface and form new bone tissue. So, and then also possibly creating titanium particles as well. So the surface itself could be involved in these processes. Even when you place an implant, if you're like, some people I know like to do the osteotomy, and they place the implant and get stuck, and then they back it out and then put it back in a little more and back it out again to kind of try to like tap it with the implant itself, but if you're doing that, you're also kind of like removing the implant surface by just like grinding it up and down against the bone. And so these kinds of things can actually affect the implant surface and the compatibility, I believe, with the bone and soft tissue.
There's a question here. Is what recommendation when the interproximal contacts loss occurs? What do you do?
Yeah, so let me just show this picture here. You might have different types. I would recommend, trying to use screw retained restorations if possible. If you need to replace the restoration, obviously that's a lot easier than like drilling, through cement retained crown and trying to replace that. But there's a few other options depending on the patient. Like if you look here, this is a virgin tooth, so you don't really want to do anything to this tooth, but if you want to adjust this contact here, you might have to alter the crown. If you have a porcelain crown, you're trying to add, that can affect, like the reheating process of it can affect the integrity of the crown. So I don't think that's recommended. But if you can have a screw retained crown, maybe doing a new crown, or in this case over here, you see that there's like actually an MOD filling on this tooth. So instead of altering this one, you can actually just alter the filling here and just increase the contact, or just, alter the contour to create a contact with this tooth. And that might actually be an easier solution, as well as performing non-surgical or surgical therapy based on the situation with the implant to address the peri-implant disease. And then the other thing that I discussed also was using a retainer. So I would try to prescribe an occlusal guard for the patient, not only to protect them from the effects of parafunctional habits, but also hopefully to retain the position of the natural tooth adjacent to the implant site.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator